How do you diagnose acute pancreatitis? Why does acute pancreatitis happen? Today, we're going to go through the pathophysiology of acute pancreatitis. I'm going to teach you how we can use clinical history, exam, labs, and imaging to make the diagnosis, how we define the diagnosis. We're going to do it all. Let's go. Welcome back to Citizen Surgeon. My name's Dr. Eric Pearson. I'm a pediatric surgeon, and we're going to do acute pancreatitis. If you watched the last video, we talked about all of the causes of acute pancreatitis. We went through get smashed, and some people added in the comments, I get smashed, or that I for idiopathic, okay? So if you haven't checked that out, definitely check that out after you watch this video on diagnosing acute pancreatitis. So the first thing we need to talk about, we talk about it all the time, and that is why. Why do we want to know this? Well, acute pancreatitis is pretty common. And if you are a surgical resident or a medical student on a surgery service, it's chances are that you either have a patient with pancreatitis on your service right now, or you're going to meet them one in the next little while. So it's very common. And if we looked at the incidence, so that's the number of new cases per year, we see 5 to 35 per 100,000 people. So if we looked at the prevalence or the number of cases at any given time, we're looking at 10 to 100 per 100,000 population. So because acute pancreatitis is so common, we can see that there is an annual cost on our healthcare system in the US of about $2 billion. Now, we're going to talk a lot about different types of acute pancreatitis. And later in the video, I'm going to define each of these, all right? So you want to stick around for that. But if we take acute pancreatitis in general, about 15 to 20% of people are going to progress to severe acute pancreatitis. About 15% of people will progress to necrotizing pancreatitis, and about half of those will progress to infected necrotizing pancreatitis. So if we look at the mortality for acute pancreatitis, what is it? We can see that from 2% on the low end to up to a quarter of patients with acute pancreatitis have a risk of dying or have a risk of mortality from this problem. So now that we have an idea of how important acute pancreatitis is, what is the pathophysiology? Why does it happen? So first we have an inciting event, and you can check out this little diagram here, but we have an inciting event. And I want you to think back to all of those causes that we talked about. So think about I get smashed. So could be idiopathic, so we don't know, but most commonly gallstones or alcohol are going to cause the activation of trypsinogen. So trypsinogen is the precursor form of trypsin. Another name for a precursor form of one of these enzymes is a zymogen. So trypsinogen is a zymogen, and when it is activated by some inciting event, all right, it causes that vacuole rupture in the acinar cells of the pancreas. Okay, and that is going to release trypsin. Trypsin is now going to activate all of those other enzymes. So we have amylase, we have lipase, we have proteases, we have lipases, we have nucleases, all these different enzymes that start breaking down different material, whether it's sugar, protein, fat, or nucleic acids, are now released from the acinar cells of the pancreas. Okay, and that can start this vicious cycle of activation of enzyme and tissue breakdown that is the pathophysiology of acute pancreatitis. Now, because we're getting tissue breakdown, we're getting inflammation, we're going to get microvascular damage. All those small capillaries that are supplying the pancreas with blood, which is oxygen and nutrients, is going to get interrupted and damaged. That's going to cause ischemia to the pancreas and edema or swelling, fluid collection around the pancreas, and that it may lead to pancreatic necrosis. Now, when we have cell damage, what happens? When a cell is damaged beyond repair, we have two routes. Number one is apoptosis. Okay, so that is programmed cell death. And that is very organized, and that's when a cell can no longer repair itself. It is going to become apoptotic and have a programmed way to die. A second way is necrosis. Now, necrosis is when the cell is obliterated, okay? And that happens in more severe forms of acute pancreatitis. But it's important to understand that once this inciting event causes trypsinogen to be activated to trypsin, that is going to cause a cascade or a release of enzymes that can cause further tissue damage and revolve this cycle, which is going to increase unless we can interrupt it with therapy. Now, another thing that's important to consider is, well, apoptosis, necrosis. What's important to know about that? Well, in the milder forms of severe acute pancreatitis, when a pancreatic cell is damaged, it will undergo apoptosis. And so we may see a shrinking of the pancreas or pancreatic atrophy. Well, what happens here? When a cell is undergoing apoptosis, it is going to express these apoptotic cell-associated molecular patterns, okay? And those are recognized by macrophages as like a signal, hey, I'm going to die, you got to eat me up, okay? And so macrophages will selectively start to take up those apoptotic cells. And we see that in milder forms of acute pancreatitis. In more severe forms, when this vicious cycle is just churning, okay, we don't have programmed cell death. We are having like obliteration of cells. So the pattern of cells and necrosis is a little bit different. So cells may express these pathogen-associated molecular patterns. Those are recognized by macrophages. Toll-like receptors are activated. Those will activate NF-kappa B. NF-kappa B will inhibit apoptosis. All right, so a couple of different patterns to think about, but generally apoptosis we're going to see in milder forms of severe acute pancreatitis, and necrosis we're going to see in the more of a wildfire pancreatitis. Okay, more severe forms that are generally associated with complications. And we're going to talk about that in a little bit. And so that is a good intro. We talked about why we need to know about acute pancreatitis. Then, of course, we just went through the pathophysiology. Now we're going to get through part 2, which is diagnosing. Now, to diagnose it, part of diagnosing is classifying, okay? In a lot of surgical diseases, we need to classify it. Maybe if we're looking at diverticulitis, we need to know the Hinchey classification system for diverticulitis. Well, the same is in pancreatitis, okay? So we have different types of pancreatitis, and I'm going to go through and define each of them here. So first is mild acute pancreatitis. Well, what is that? Well, in mild acute pancreatitis, we have a diagnosis of a pancreatitis. So stick around, I'm going to tell you what that is, okay? But we don't have any organ failure. We don't have any complications, and we don't have any evidence of necrosis. So that is mild acute pancreatitis. Well, moderate severe acute pancreatitis steps it up a notch. So now we get transient organ failure that lasts less than 48 hours. We have local or systemic complications of that pancreatitis that last longer than 48 hours. And if we do have necrosis, that is sterile, non-infected necrosis. So that is moderate severe acute pancreatitis. Now, if we step it up a notch and we go to severe acute pancreatitis, well, what is that? Well, that's if we have organ failure, so end organ failure that lasts greater than 48 hours, or now we have infected pancreatic necrosis. So you can see that in severe acute pancreatitis, there is an or. So we either have organ failure that's lasting longer than 48 hours, or we have infected pancreatic necrosis. Now, finally, when we get to critical acute pancreatitis, we have organ failure that's lasting longer than 48 hours, and we have infected pancreatic necrosis. So to go over each of these again, we have mild acute pancreatitis, okay? So no organ failure, no necrosis, no complications. Moderate acute pancreatitis, which is if we have any organ failure, it's less than 48 hours. We may have some local or systemic complications, and if we do have any necrosis, it's sterile. Then we have severe acute pancreatitis, which is organ failure greater than 48 hours or infected pancreatic necrosis. Then, of course, critical pancreatitis, which is both organ failure lasting longer than 2 days and infected pancreatic necrosis. So now that we can classify it, how do we diagnose it? So diagnosing acute pancreatitis. Well, we can diagnose by taking a good history, doing a thorough physical exam, getting some labs. I'm going to show you which ones are important. Then, of course, imaging. All right. So how about that history? What questions are important and what does a history usually look like? So first, going back to I get smashed. So we want to ask the patient, can we find out, are there any clues to a possible cause of pancreatitis if a patient presents with acute abdominal discomfort? So we go through get smashed. Okay. So gallstones and ethanol or alcohol, those are going to be the two most common. Then we have trauma. We got scorpions, mumps. We have autoimmune disease. We have steroids. We got hypercalcemia, hypertriglyceridemia. We have ERCP. We have drugs. So we got to go through each of those, find out, is there a clue in the history? Well, then we go to our pain history. So remember that one. So SRNOPDSARA. If you haven't checked out that video, check out that video up there, how to take a pain history. So site, radiation, nature, onset, periodicity, duration, severity, aggravating, relieving, and associated. Okay, so we take our pain history, and what does that look like in a patient with acute pancreatitis? Well, the pain is usually in the epigastric region. It can radiate to the back. Sometimes it's in the right upper quadrant, okay? And it's typically constant. Those are the real features with acute pancreatitis. So a constant epigastric pain or right upper quadrant pain, especially if it's radiating to the back. Now remember, where is the pancreas? So the pancreas, as I heard when I was at first day of medical school, one of my anatomy professors, okay, he was a surgeon in Ireland, and he said the pancreas is deep, it's dark, and it's dangerous. And if we remember, the pancreas lies right over the spine in the retroperitoneum. So when it's inflamed, not only can it cause that epigastric pain, but it can also cause pretty severe back pain. Now, a couple of things to keep in mind. We can have rapid onset of the pain in gallstone pancreatitis. So a gallstone comes out of the gallbladder, goes down the cystic duct, down the common bile duct, and gets lodged in that ampulla of Vater where it obstructs pancreatic outflow. That causes severe inflammation. That type of pain is rapid onset. In the majority of patients, when we get to that associated part of the pain history, so associated symptoms, the majority of patients have nausea and vomiting as well. Now, how about the physical exam? Well, what does the physical exam look like in somebody with acute pancreatitis? Well, patients can present with fever, tachycardia, tachypnea, and hypotension. So as the pancreatitis progresses, we may have abdominal tenderness, may have abdominal distension, perhaps an ileus, and there are some physical signs associated with acute pancreatitis. Now, when we look at specific physical signs of acute pancreatitis, there are a couple that always come up, it seems, on rounds or in the operating room. And so that is Gray-Turner sign or Cullen sign. Now, these don't happen often. Only about 3% of patients present with these signs, okay? And when we look at Gray-Turner sign, well, that is when we get bruising or ecchymosis in the flanks, whereas Cullen sign is when we get bruising or ecchymosis around the umbilicus, okay? So why do these happen? All right. Why do we get these? What is the pathophysiology? So the pathophysiology of both of these is retroperitoneal bleeding. So in Gray-Turner sign, in that severe acute necrotizing pancreatitis, we get retroperitoneal hemorrhage, and that comes out to the flanks. So dissects through the retroperitoneum. In Cullen sign, we see the same thing where it comes around ligamentum teres and you get that periumbilical ecchymosis. And these two findings can be not only in severe pancreatitis, but also in other forms of retroperitoneal hemorrhage. But if you see this in somebody that has that history, those questions we've asked that goes along with acute pancreatitis, we really have to be thinking that acute pancreatitis could be the diagnosis. So let's get into labs. So what are the labs that we're going to look for in acute pancreatitis? Well, the one that comes to mind straight off is amylase and lipase. So let's talk about amylase. Now, amylase is produced in the pancreas. It rises 6 to 12 hours after the onset of acute pancreatitis, and it has a half-life of about 2 hours. Now, we can say that it has a low sensitivity in diagnosing alcoholic pancreatitis because in alcoholic pancreatitis, we have chronic pancreatic damage. And so there isn't a lot of amylase to be expressed. We also have a low sensitivity in pancreatitis caused by hypertriglyceridemia, and that's because the high triglycerides interfere with the assay to detect amylase in the serum. So those are things to keep in mind when it comes to serum amylase as a marker for acute pancreatitis. Now, how about lipase? Well, serum lipase, many would argue, I think the literature supports that this is a much better marker for acute pancreatitis if we're making a diagnosis. Now, this typically rises earlier, so 4 to 8 hours after the onset of pancreatitis. It has a longer half-life, so 7 to 10 hours compared to 2 hours. Serum lipase typically peaks at 24 hours, and it decreases over 4 to 8 days. Now, as opposed to amylase, we just talked about, amylase usually peaks a little bit earlier and it decreases or is cleared more rapidly. So sometimes we can miss a diagnosis of pancreatitis if we're using amylase. So lipase, for many reasons, including its increased sensitivity in alcoholic pancreatitis and including its increased sensitivity in triglyceride-related pancreatitis, is a better marker for diagnosing pancreatitis. Now, what levels of amylase or lipase are important when it comes to making the diagnosis? So in a patient that presents with acute abdominal pain that is consistent with acute pancreatitis, amylase or lipase levels greater than 3 times the upper limit of normal is consistent with making a diagnosis of acute pancreatitis. Now, are there any other labs that are important? Well, I think a CRP is another great lab to get in acute pancreatitis. Now, we know that if we have a CRP that's greater than 150 milligrams per liter at 48 hours, this is a marker of more advanced disease. Now, I will get a CRP in addition to my amylase and lipase so I can get an idea of how severe the inflammation is. Now, other labs, of course, you're going to get a CBC. You're going to look for a white cell count, anemia, platelets. You're going to be getting a BMP and looking at all of our electrolytes and probably a complete metabolic panel that's going to also include our bilirubin so we can see, is this gallstone-related pancreatitis? Do we have choledocholithiasis, maybe obstruction of our common bile duct? So a complete blood count, a complete metabolic profile, an amylase and lipase, as well as a CRP is kind of the minimum lab set that I would get when I'm trying to work up these patients and make a diagnosis of acute pancreatitis. Okay, so now we get to imaging. This is kind of the fourth thing. We got history, physical exam, labs, now imaging. So what's the most common imaging almost everybody gets in the ER? Well, a plain film x-ray. Well, can a plain film x-ray help you in a diagnosis of acute pancreatitis? It can, all right? So what would you see on a plain chest x-ray? Well, on a plain x-ray, you may see a pleural effusion. Okay, that could be on the left or the right side. Remember, this would be a sympathetic infusion caused by inflammation of the diaphragm. On a plain x-ray, you may see atelectasis, may even have a pulmonary infiltrate. We may also have ARDS, or acute respiratory distress syndrome. We may have an elevated diaphragm caused by abdominal distension and ileus. And then, of course, we could see ARDS if we have really severe pancreatitis that is causing multi-organ failure. So these are the things that we may see and you need to look out for on that chest x-ray. Well, what would be the next x-ray that would be very common? Well, how about just a plain film of the abdomen? Well, the common things to see in a plain film of the abdomen would be an ileus. So we have multiple dilated small bowel loops. We could have a sentinel loop sign. So if we have severe inflammation of the pancreas, we may have a kind of a paralyzed duodenum or proximal ileum. So we see a big dilated proximal loop. That's called sentinel loop sign. So we may have a colon cutoff sign. So that's when we have dilated proximal colon up to the splenic flexure, and then we get an abrupt cutoff. So we see that in severe acute pancreatitis. We could also have a gasless abdomen, so we don't see any loops at all, and so we may see ascites, and that's when air-filled loops are kind of pushed towards the middle or the central abdomen, and that acidic fluid surrounds them. Now, those are some of the features of a plain abdominal film. Well, what's next? How about an ultrasound? Well, an ultrasound could be helpful, number one, in establishing the etiology. So do we see shadowing gallstones in the gallbladder? Do we see a dilated common bile duct? Are there findings of gallstone pancreatitis? So we can see mesenteric thrombosis. Usually this is venous and associated with severe acute pancreatitis. We can see areas of infected pancreatic necrosis, and these would be hypoechoic areas of the pancreas that are associated with necrosis due to poor perfusion. Now, I should say that an ultrasound of the pancreas can be quite difficult if we have multiple dilated air fluid or even fluid-filled loops enter the pancreas, all right? So they may preclude us from getting a good view of that pancreas. But if we do get a good view, these are some of the signs that we can look for. Well, what are some other things? We can see edema, we can see organ displacement, and we can see enlargement of the pancreatic volume. So some of the things to keep in mind and why ultrasound can be particularly helpful when making the diagnosis of acute pancreatitis. Now that brings us to cross-sectional imaging. So a CT scan. Now a CT scan is a really great modality when looking for pancreatitis, because not only is this going to help you make the diagnosis, but we can also look for complications of acute pancreatitis. And we're going to talk about those complications in a different video. So what are some of the findings that we can see on a CT scan of the abdomen looking for acute pancreatitis? Well, we can see parenchymal enlargement. We can see edema. We can see indistinct borders of the pancreas because of that edema or swelling of the pancreas. We'll be able to see the fat stranding that's caused by that severe inflammation. We'll be able to see necrosis or dark areas of the pancreas that are poorly perfused. If we have a superimposed bacterial infection of the pancreas, we can see emphysematous pancreatitis, where now we see spots of gas through the pancreas produced by that bacteria. We may see an abscess in the pancreas. So if we have a walled off necrotic pancreatic collection that's now been infected, that can be an abscess. We can see fluid collections, so pseudocysts associated with pancreatitis. We're going to talk about that in the next video. Then, of course, we can see retroperitoneal fat necrosis and calcification if this is something that is chronic, again, going on for a longer period of time. So you can see with all these features how helpful cross-sectional imaging with a CT can be in making the diagnosis of pancreatitis and seeing how severe it is and if there are any associated complications. Well, the next one would be MRI. Now, what are the findings in MRI? The findings in MRI are really the same as they are in CT. So either of these, if you want to avoid radiation, MR can be helpful. But because of distortion of the image in pancreas due to breathing movements and things, CT is very, very effective, maybe even better than MR. Okay, so I hope you found that helpful today. Today we talked about pancreatitis, and specifically we talked about the pathophysiology of acute pancreatitis. Why does this happen? You get that vicious cycle, okay? We can get apoptosis or necrosis of these pancreatic cells depending on the severity of pancreatitis. And then we went through how to diagnose. We talked about the history, physical exam, the important labs, and of course, all these imaging modalities. I hope you liked it. If you did, give it a like, share it with your friends, and engage in the comments. I love it when you guys ask questions, and I love to get back to you. So check out CITIZENSURGEON.com. Well, I got a bunch of videos in the library, and I got show notes on the website, CITIZENSURGEON.com, that can help you make it through these videos. As always, stay safe, study hard. I'll see you next time.